Hello and welcome to another neurological video. We're going to be talking about the other neurologic diseases that were not covered in the other videos. We're mainly going to be focusing on nutritional deficiencies. So these are specific neurological disorders that are seen when we talk about nutritional deficiencies. And the main ones that we'll be discussing is B1, B12 and folate deficiency. So starting off with thiamine or vitamin B1 deficiency, we have two different disorders. We have Wernicke encephalopathy, and then we have Korsakoff dementia. Okay, so we'll talk about Wernicke's first. Wernicke's is the more acute, subacute syndrome when a patient has B1 deficiency, and they have a classical triad of encephalopathy, ophthalmoplegia, and ataxia. The kinds of patients that you're going to be seeing with Wernicke encephalopathy are usually chronic alcoholic patients. And this is because the toxins in alcohol damage the Purkinje cells in the cerebellum, which is the main cells that you find in the cerebellum. Here it does say that acute and chronic alcohol can be the cause, but even in acute cases, it's usually acute superimposed on a chronic alcoholic patient. Other patients could be people with hyperemesis, prolonged hyperemesis, starvation, renal dialysis, and even AIDS. Okay, anybody who you would believe has a lack of B1 in their diet. And something that's very high yield to know is that Wernicke's is usually brought on by patients who have recently had a high dose of glucose administration. Because when you have B1 deficiency, that causes a backlog of a lot of gluconeogenesis compounds, okay? And when you give, glycolytic pathway compounds. And when you give glucose, you're shunting into that same pathway, so those intermediates build up. So even though the patient may be malnourished, for example, whether it be AIDS, alcohol, renal dialysis, when you give glucose, you're potentially worsening the problem. So the key here is to always give thiamine before you give the glucose, and this is going to prevent that buildup of the glycolytic pathway metabolites that cause Wernicke encephalopathy. Wernicke's is generally reversible, okay, and that's in contrast to Korsakoff, which we'll talk about now. So Korsakoff dementia, this is the sort of consequence of an untreated thiamine deficiency. And this is characterized by an anterior grade and retrograde amnesia. Alongside that amnesia, you're usually going to see nystagmus and often confabulations. So if you're dealing with a case that's got sort of amnesia, and you also see the signs of confabulation or nystagmus, this is pointing more towards a Korsakoff dementia. The type of patients that have Korsakoff dementia are exactly the same as Wernicke's: chronic alcoholics, AIDS patients, renal dialysis patients, but it's going to be a patient who had Wernicke encephalopathy but was not treated or was too late to treat it. And the bad thing about the Korsakoff dementia is that this is an irreversible side effect. Okay. Obviously, when somebody has vitamin B1 deficiency, they may also have beriberi as well. And beriberi is not the neurological syndrome from thiamine deficiency, it's the metabolic consequence. So we will cover that in another module, but we have dry beriberi and wet beriberi. Dry beriberi is a neuropathy, and wet beriberi is a type of heart failure. It's actually dilated cardiomyopathy. But just look out for that in these patients as well. Now we're going to be moving on to B12 deficiency. So B12 is obviously found in a lot of like dairy products. It's also found in meat. So this is really, really common in vegans. B12 can cause a whole array of different signs and symptoms, but from a neurological perspective, it causes a famous disease called subacute combined degeneration, okay? And this is what that looks like when you look at the spinal cord in a cross-section. There's 3 specific tracts in the spinal cord that are affected with subacute combined degeneration. That is the dorsal columns, as you can see here, the spinothalamic tracts, which you can see, and then also the corticospinal tracts as well. So the signs and symptoms we have is a gradual progressive gait disorder, and this is due to the lack of proprioception. The lack of proprioception because our dorsal columns are destroyed, okay? We also get asymmetrical paresthesia, stocking or glove stocking sensory neuropathy. This is due to the spinothalamic tract being degraded. And then we can also get leg stiffness, spasticity, paraplegia, and bladder and bowel dysfunction. And these are usually due to the lateral corticospinal tract being affected. Patients can also have a sore tongue. They get a sore tongue because B12 is associated with a beefy red glossitis. That's why. And we can also have dementia in patients with B12 as well. Just from a biochemical standpoint, we do have the elevation of methylmalonyl-CoA and also homocysteine. So add that to your notes if you don't have it, but it's methylmalonyl-CoA and homocysteine which are elevated. Of course, patients with cobalamin deficiency are also going to have anemia, okay? And if you remember, it's a megaloblastic anemia, so the MCV is going to be elevated. It's going to be above 100. Just on a sort of more kind of pathophysiology perspective, this is more important for step 1, but the reason why a B12 actually causes a subacute combined degeneration is due to the buildup of this methylmalonyl-CoA. So the methylmalonyl-CoA is actually toxic to myelin. So this is actually causing demyelination of the dorsal columns, spinothalamic tract, and corticospinal tract, causing this sort of sequelae of symptoms. So the kinds of patients that have B12 deficiency are patients who are strict vegetarians, okay? Patients with pernicious anemia meaning an autoimmune against the parietal cells and intrinsic factor. And you should be aware that intrinsic factor is a molecule that protects vitamin B12 from being degraded, so it can be absorbed in the terminal ileum, okay? So look out for that. Anybody who's got post-gastric resection or ileal resection, and that's because of exactly what I've just mentioned. Intrinsic factor is produced in the stomach, so if we don't have a full gastric sort of stomach, i.e. if somebody has gastric sleeve bypass for bariatric surgery, these patients will lack the lining of the stomach that produces intrinsic factor, which is then going to assist B12 absorption. Ileal resection or ileal disease, such as Crohn's disease. When we talk about GI and when we do the GI module, you will see that Crohn's most commonly affects the terminal ileum. So these specific elements will mean that we don't have absorption of B12, since B12 is absorbed in the terminal ileum. And then obviously patients who have acute or chronic alcohol overuse or other types of malnutrition. How do we treat it? B12 injections, or large oral doses, but we tend to give B12 injections. If you've ever been to your GP or to another doctor's, you'll often see them administer the B12 injections intramuscularly into the buttock. And then last but not least, when we talk about the vitamin deficiencies, we're going to be talking about folate deficiency. So folate deficiency is way more common than B12 deficiency because the storage of folate is not as much, but yet it's required way more than B12. The kinds of things we will see is irritability, personality changes, all these kinds of signs, but we don't have neurological symptoms like subacute combined degeneration, okay? Obviously, when somebody has folate deficiency, they're also going to have anemia as well. So a patient has anemia, it will be megaloblastic again, so the MCV will be elevated, but they don't have any pins and needles in the legs. They don't lose proprioception. They don't have spasticity, okay? So they don't have the signs of subacute combined degeneration. That is only seen in B12. In regards to the methylmalonyl-CoA, we don't see that in folate deficiency, but we do see an elevation of homocysteine, okay? So homocysteine is elevated in folate, homocysteine and methylmalonyl-CoA are elevated in B12 deficiency. What kinds of patients have folate deficiency? Chronic and acute alcohol overuse. It may also be seen in patients who are pregnant. That's why we always advise women who have pregnancy to take folate. And if you remember, if somebody is folate deficient in pregnancy, this increases the risk for neural tube defects. Okay, and again, we can just give oral folate and that can assist in any deficiency. Okay, now we're going to be moving on to idiopathic intracranial hypertension. And this is a disorder that is characterized by raised intracranial pressure, and we have a specific set of neurological manifestations such as headaches, papilledema, which is actually the most common, visual loss, and any indication that tells us that there is a raised intracranial pressure. The disease doesn't have a proven etiology. This is why it's called idiopathic intracranial hypertension, but it is believed to be due to a decreased resorption of CSF or an increased production of CSF. And the physically proposed mechanism is due to the transverse sinus being slightly narrowed, slightly stenosed, and that causes a decreased outflow of the CSF. There is also a bit of evidence to suggest it might be hormonal, related to aldosterone excess, and even an increased outflow resistance to CSF, which is related to the transverse sinus stenosis. In terms of our risk factors, we are looking at patients who are female, are obese, use of tetracyclines, and hypervitamin A, okay? And I have a nice little mnemonic for you, and that is female toad, okay? So female toad. So female, obviously it's more common in women. T stands for tetracyclines. O stands for overweight. A stands for vitamin A toxicity. And D, this is your extra A star one. This stands for danazol. Oh, excuse me. Danazol. Okay, this is a medication which is also associated with idiopathic intracranial hypertension. And then just on another side note, another name for idiopathic intracranial hypertension is pseudotumor cerebri, essentially just meaning that this can mimic the signs of having a tumor in the brain. So what do we see in terms of history and presenting complaint? So the patients usually have a bilateral, more frontal headache, and it's going to be worse in the mornings, same as tumours of the brain as well. It's going to be worse on Valsalva, also worse when the patient coughs, and patients can get transient vision loss, even diplopia, I'll explain why in a minute, and a pulsatile tinnitus. And always look out for this specific sign because they love to mention that in the board exams. And one of the reasons why we get diplopia is due to the abducent nerve palsy. Whenever we get high intracranial pressure, we're always at risk of getting an abducens nerve palsy. That's because cranial nerve 6 has got a very long intracranial course. Its route throughout the brain is very, very long, so it's very susceptible to being compressed. Great. How do we diagnose pseudotumor cerebri? So, the actual diagnostic test for pseudotumor cerebri is a lumbar puncture. And if we have a CSF opening pressure of more than 25 centimeters of water, this is suggestive of a diagnosis of idiopathic intracranial hypertension. However, there is something that we have to do before we do the lumbar puncture, and that is neuroimaging. And the reason why we have to do neuroimaging, usually an MRI with venography, but we can also do CTs as well. This is to rule out other causes of increased intracranial pressure, such as neoplasms, such as stenosing of the ventricular system, because these are contraindications for the lumbar puncture. Okay, so I've got to rule out other causes of these signs before I can do the lumbar puncture. We can also do an ophthalmic examination. We're most likely going to see papilledema, and we can discuss the findings of that in the ophthalmology section. And then finally, on to treatment. So the goals of therapy are essentially to alleviate the symptoms and preserve vision. These are the two priorities in this disease. Okay, the first best treatment for these patients is to essentially do lifestyle changes to address the risk factors and decrease the weight, because most of these patients are going to be overweight. Okay. In terms of the first medication we give carbonic anhydrase inhibitors such as our acetazolamide. That's the first line medication. So it's probably the second line after lifestyle changes and weight loss. When medical therapy fails, we can consider a couple of other things. We can consider topiramate. Topiramate's obviously an anti-epileptic, but one of topiramate's other effects is like a mental numbing, like a dulling of the sensations of the brain, essentially. So that can actually alleviate some of the headaches. And we can also do serial lumbar punctures. And a lot of people ask, well, why do we have to do loads of lumbar punctures? If you just do one, surely that can relieve the pressure. But CSF reforms in about 6 hours. So you've got to continuously do it. These are not going to be long-term solutions. These are purely something that we can do to alleviate symptoms prior to surgery. So that brings the next question: who needs surgery? Surgery is going to be for patients who have worsening visual defects despite the medical therapy of acetazolamide. Also, patients with visual acuity loss secondary to the papilledema, we have to do procedures as well. These specific procedures we can do is we can do CSF shunting. This can usually be ventricular portal CSF shunts, but also a very interesting procedure which involves optic nerve sheath fenestrations. And that's essentially just to relieve the pressure from the optic nerve to prevent its compression and thus to prevent permanent visual defects. So this completes the other neurological disorders. I hope that's been helpful for you. Let me know in the comments section if you have any questions, and stay safe.